Hope everybody had a good Thanksgiving weekend. I think everybody's recognized that we've had a dip in case counts across the state, in most areas of the state, which is obviously very good news, and had a couple of people asking what's going on and trying to figure that out. So I thought we would take a look at least a couple of aspects, or explore some options, and then those are things that we can see how they play out over the next week or two as we look for the effect of Thanksgiving gatherings potentially on case counts moving forward. As you can see, we've definitely taken a pretty significant decline in case counts, which peaked November 20th, so certainly well before the Thanksgiving holiday started. So I don't think any data reporting anomaly is responsible for that, although I think everything after last Wednesday obviously needs to be taken with a grain of salt, because we know that in general weekends and holidays have a significant effect on reporting, and so I'm imagining we probably had a bit of underreporting from Thursday through the weekend, and we'll start catching up on that this week. And you can see that that's reflected in deaths as well. I certainly don't think that our death count actually significantly declined at all. It should still be moving upwards, catching up with the case count. As we said, there's a 3 to 4 week lag there. So I think that is an anomaly, but clearly I think the case count, at least from November 20th up until Thanksgiving, declined about 20%. And I think that's a real effect. And we saw that in hospitals leveling off as well. And so I think that remains to be seen what caused that. I imagine that potentially some of the behavioral changes from increased emphasis had contributed. I'm not sure that a lot of the mask mandates that were thankfully enacted appeared to be enacted right around that time, so I'm not sure they had time to actually have that impact. So it may be multifactorial. Nevertheless, a good sign, but we still remain at obviously dangerously high levels, still well above 75 cases per 100,000 per day. I think that it's important to recognize there's still wide areas of the state that have very high levels of transmission, although the number of counties in that deep red category has decreased over the last 2 weeks. So that is good. One thing I think people have thought is that potentially we reached some natural ceiling of the epidemic or herd immunity threshold. And I think that we have some recent data that helps us to look at that. So the CDC just came out with their latest details of their commercial sero survey laboratory study. So as you may remember, we've talked about this before, the CDC has been analyzing tens of thousands of samples across the country, which are remnants from commercial laboratory testing. So should be a relatively wide general representation of the population, not necessarily anybody who has symptoms or history of COVID, but anybody who had a laboratory test drawn for any reason. And they take the serum from those tests and they run serological assays to see who has antibodies against the coronavirus. And if you look down on the line graphs here and find Nebraska, where I will float my cursor, there we go. You can see here that we were relatively consistent over the summer. And again, this, there's a pretty significant time lag here. So the latest data we have is from early September. Where Nebraska's seroprevalence rate was a little less than 7%. So you can see here this data from early September shows 6.7% seroprevalence. So that means essentially close to 7% of Nebraskans at the time had evidence of infection. We'll go into detail about what that means for true cases in a little bit. But I think, when you break it down by age, unfortunately, Nebraska does not have data on pediatric cases. But if you look at data from the other states that do, the seroprevalence in the age group 0 to 17 was generally the same or higher than what it was in older populations. And what's more interesting is if you look at the trends in most of those other states, seroprevalence in that age group increased significantly from midsummer until September, obviously when schools had been opened. So that's something that we'll potentially explore later. But unfortunately, Nebraska doesn't have that data, but you can see that the breakdown is relatively consistent across the age groups there, and relatively consistent between males and females. These are the 4 time periods where Nebraska's seroprevalence data had been collected, and you can see pretty much consistent across the summer. Even though there are rising case counts, it was not precipitously rising in that period between the beginning of August and mid-September. There is a margin of error associated with each of these. So if you take the average of around 7% seroprevalence and you look at the number of confirmed cases that were present at the time versus the number of cases that would be estimated by the seroprevalence rate, you can assess by what factor we are underestimating cases with our laboratory confirmed cases. And I think we talked earlier in late summer that I thought we were underestimating by about a factor of 5 to 7, and now it looks as if with increased testing, we're only underestimating by a factor of 3 to 4. So roughly estimating in the middle there, about 3.7 would be our ascertainment factor. So if you think about the number of true infections that we probably had at the end of August, that's taking that seroprevalence rate and applying it across the entire state of Nebraska, you can estimate we had about 145,000 Nebraskans had been infected by August 31st. We've had 91,000 confirmed cases since the beginning of September. And so if you multiply that by 3.7 and then add 145,000, that should give you our estimated true infections, now at the end of November. So that's 482,000. So that equals a community attack rate of about 25%, which is, I think, where a lot of us expected we were. That's about where New York City was at the end of their large spring wave, and we've had an experience in terms of case numbers, certainly that approach that. So you can estimate that we've had a community attack rate of about 25%, which is well below what we think the herd immunity threshold should be of at least 60%, maybe closer to 70%. So I don't think that the dip we're seeing is because we've hit any kind of ceiling in terms of the epidemiology of disease. I think it is probably much more likely to be explained by some behavior changes and maybe some other factors. And we'll see if we negate some of those gains through transmission events that occurred over Thanksgiving. And I expect over the next week or two, we will again see case counts increase, but let's hope not. So that's all I have. Thanks, Shelley.